Today's topic is cholinergic antagonists, and cholinergic antagonists are uh, drugs that block the cholinergic receptors and that will inhibit the uh, cholinergic activity, including the parasympathetic system. And these drugs are not used common in uh, in clinics, but some of them are used to treat the overdose, and also some of them are used uh, for the um, for the research purposes. So the mm, the classification includes the three groups. First group is anti-muscarinic agents. Anti-muscarinic agents are most common, and atropine is the principal um, drug, and most of the properties of atropine are studied first with in uh, in pharmacology, and also all other drugs are either derivatives of the atropine or the chemical compounds that have the same properties as atropine, including benztropine. Benztropine is a longer acting analog, and also the ipratropium is most useful, clinically useful drug, and is indicated for the treatment of the asthmatic patients. And ipratropium is has a common structure with the atropine, and the only difference is that ipratropium is not absorbed and it's administered by inhalation. Then scopolamine is also naturally occurring substance, and scopolamine is used for treating the motion sickness, including the sea disease and air disease. So scopolamine is another very useful, clinically useful agent, and also now available as transdermal patches. So this transderm scope is a brand for the transdermal scopolamine, and also other drugs like tropicamide and also tiotropium are mostly used in ophthalmology for the during the eye surgery or for the diagnosis of the eye diseases. So the main purpose of this are to lead to cause a mydriasis, so the increase in the uh, in the size of the pupil, that makes it easier to see uh, the retina and to diagnose the different eye diseases. Then the nicotine is not a drug, but is used for smoking cessation. Now also in the transdermal patches for the Nicoderm brand. And also neuromuscular blockers are not used commonly for the treatment, but some of them are used to prepare in the surgery, or to prepare the patient for the surgery, and also for the giving inhalation or narco narcosis. So so for the inhalation anesthetics, the neuromuscular blockers can be used for prior the administration of the anesthetic. So for the general anesthesia, so these are the uh, uh, cholinergic blocking agents. So the difference between the antimuscarinic agents and the ganglionic blockers is that antimuscarinic agents will block M cholinereceptors, ganglionic blockers will block the nicotinic or N cholinereceptors, and the neuromuscular blockers will block the nicotinic muscular type that is actually in skeletal muscles. So the sites of action of the ganglionic blockers or nicotinic receptor blockers are in the sympathetic and parasympathetic ganglia. So, and the site of action of the antimuscarinic agents is in parasympathetic postganglionic neurons, and site of action of the neuromuscular blockers in somatic uh, neurons. We have a nicotinic muscular type receptors. So nicotinic receptors for the ganglionic blockers and neuromuscular blockers, and muscarinic receptors for the anti-muscarinic drugs. So then the mechanism of action of the atropine and scopolamine is that they bind with the muscarinic receptor and prevent acetylcholine from activating the receptor, while they don't activate the receptor themselves. So this is a common mechanism for most of the antagonists, and is actually the antagonist is competitive. That means that if we increase the concentration of the acetylcholine, it will replace the atropine, and vice versa. If we increase the concentration of the atropine, it will replace acetylcholine back. So whoever has higher concentration near the receptor, uh, the predominant action will be of that agent. So it can be atropine, scopolamine, acetylcholine, or any other drug. So these are the symptoms for the atropine overdose. So because atropine is a strong acting drug and is toxic, so the in therapeutic doses, atropine will lead to the bradycardia, that because of this blocking of the M2 receptors in the heart. Then some dryness of the mouth because of the inhibition of the parasympathetic nervous system, and that will activate the sympathetic nervous system and also will inhibit the sweating. So these are the classic parasympathetic system inhibition or sympathetic nervous system activation, except for the bradycardia, because bradycardia is because of the direct action on the heart. Then the increase in the dose of atropine up to 5 mg will lead to the tachycardia, palpitation that will, um, because of the rapid heart rate, then dryness of the mouth will be most severe, and we will see the dilation of the pupil, because in that dose the atropine will act on the eye too, and then some blurring of the near vision because of this action on the eye and the accommodation disruption. So that is the action on the eye. And in higher doses, higher than 10 milligram, atropine will lead to the death. This also includes hallucinations and delirium. The patient will have a delirium and then go to the coma and eventually will die. So atropine is very dangerous, so that is why be careful while working with the atropine. Also when dispensing the atropine, make sure the dose is not higher than 5 decimilligram. So actually half milligram dose is the maximum that is allowed. So the neuromuscular blockers will also act on the uh, nicotinic receptor, and that will inhibit the acetylcholine activation of the receptor, and the sodium channel will be blocked, so there will be no contraction. So this is the will relax uh, or the muscle, and the patient cannot move actually. Procuronium, and other tubucarin and other neuromuscular blockers will lead to the relaxation of the muscles. So these are all for today, and I think that um, that is all. Do you have any questions?
No, thanks, teacher.
So please make sure that you are prepared for the test for the next week, and see you at the university. So hope if you have any questions, so please send me your questions, and be prepared for the text for the next week.
Okay.
Okay, Doctor. Goodbye.
Bye bye.
Bye.